Good afternoon, everybody. I'd like to welcome members to this afternoon's in-person meeting of the Rutland Health and Wellbeing Board and to members of the public who are listening in via Teams. We have another busy agenda for today's meeting, so firstly to practical matters. We're not expecting a test of the fire alarms, so if the fire alarm does sound, could attendees please exit the building via the nearest exit. The rallying point is the rear of the car park. I'd like to remind attendees that they need to please raise their hand if they wish to speak, and that for the benefit of the webcast and the recording, they need to switch on their microphone when addressing an item and switch off when they have finished speaking. I'll refer to the scrutiny officer from Democratic Services if I need to record a vote or for any procedural matters. Thank you. So moving first to apologies. Jane, have we received any apologies?
Thank you, Chair. Yes, apologies have been received from Karen Kibblewhite and David Williams, but we have Alison Gilmore in attendance as David's representative.
Thank you, Jane. So the record of meetings. So this is to confirm that the minutes of the Rutland Health and Wellbeing Board meeting on the 16th of January 2024 are an accurate record. Would anyone like any amendments making to the minutes? No. I was not able to attend the January meeting, so I'd like a proposer for the minutes, please. Thank you, Mike. A seconder, please. Thank you, Tim. All those in favour, please raise your hand. Counting, thank you. Anyone against, please raise your hand. And abstinence, me. And 2, Sarah. Thank you, Chair. So minutes are now confirmed.
Thank you, Chair.
Actions arising. There are no actions arising from the last meeting, so we move on to agenda item 4. Any declarations of interest for this afternoon's meeting? No, none. Petitions, deputations and questions. Have we received any petitions, deputations or questions?
None received, Chair.
Thank you, Jane. Questions with notice from members?
None received, Chair.
Notice of motion from members?
None received, Chair.
Perfect. Gone through them. Now, we have the first 2 items on the agenda we have some visitors today. So number 8 is the Right Care, Right Person overview and update. It's a verbal update from Chief Inspector Audrey Danvers of the Right Care, Right Person approach. So could you come to the table and present to the board, please? Can I call you Audrey? Can I call you? Oh. Sorry.
Can I confirm you can? Oh, you can definitely hear me, can't you? I'm all right. Yeah. Good afternoon. I'm Chief Inspector Audrey Danvers. I'm currently based within the Contact Management Department at Force Headquarters. I've been asked to come here to give you a bit of an overview of Right Care, Right Person. Can I just ask, just so I get a flavour as to the floor, how many of you have heard of Right Care, Right Person? Right, and you may all have, or at least there's a reasonable amount of understanding in relation to it. Right Care, Right Person basically came about because I think there's been a recognition over particularly the last 5 or 10 years that the police get involved in lots of matters which were perhaps not best to take primacy on, particularly those relating to people in a state of vulnerability, mental health, etc. And Right Care, Right Person is effectively a threshold that gives an overview and outline as to when the police will get involved in relation to certain matters. For yourselves as a health board, there are probably 2 key areas which would impact upon yourselves, and that would be people who go absent without leave from mental health establishments. That's usually in Leicester, it's usually sort of the Bradgate unit, sometimes Arnold Lodge, and also walk out from healthcare places, again usually in Leicester, it's usually the Leicester Royal Infirmary. In addition to that, there are 3 other strands that also relate to Right Care, Right Person. Those are concerns for welfare, transportation and the police use of mental health powers. But as I said, it will be those 2 key strands, the going absent without leave and also those who are absenting themselves before they've actually received treatment for mental health, from health establishments, which are probably going to be the 2 that most partners become involved in. What ordinarily happens is partners contact us to say someone's gone from the Bradgate unit or someone has gone from the Leicester Royal Infirmary. We, traditionally the police, have then got involved. We begin to search for the person, we undertake checks, etc. And it's been recognised that actually we're not best placed to do that, particularly for the people who are in mental health crisis. And a number of times we've actually realised that we don't have the powers to do that. So just say, and again I'll give you a bit of a real example, but slightly anonymised. Somebody is at the Bradgate unit, there's a voluntary patient, they've not been sectioned, they leave the premises. The Bradgate unit then contacts us to find that person. We don't have, unless there is an immediate threat to that person's life, we don't have any powers to do anything with that person at all, other than to try to persuade them to return. And bear in mind, you might be dealing with someone who might have some mental health challenges. So what it has been, it's been recognised actually we're not best placed to deal with that. So what we have been doing, and we've constructed a document, considerations before you call document, which has been circulated to all the partners, to actually say, before we are contacted, there are sets of considerations that partners really should go through before they contact us. So if there is any inference that there is a threat to the person's life or immediate safeguarding, anything involving child vulnerability, etc., any sexual exploitation, etc., then by all means contact us. But what we are doing is changing the focus of the partner agencies to, instead of them automatically contacting us, to actually see what the partners themselves can do before they make contact us. So what we're asking for is the various institutions and establishments to make their own inquiries in trying to contact, for example, a person who has gone missing, or trying to locate a person. And it's after they've exhausted those inquiries and they realise actually that they potentially can't contact the person and potentially there might be a threat to that person's life, health or welfare, that we might become involved. So right care, right person is really about just that. It's about ensuring that the focus is to get the right person to deal with that person rather than it always sitting with the police. Because I say consistently, it's been found, particularly over recent years, that the police are spending a lot of time dealing with matters which we're not really best placed to take primacy for. So that's really a bit of a, and I've only got 10 minutes, a bit of a brief summary about what right care, right person is and the impact that it might have on yourselves and the partner agencies that you actually work for. What you might find is that as opposed to a police officer being dispatched to an incident or to a job, that we're probably going to be asking the agencies, well, actually, what have you done? So the onus is pushing back onto those agencies for them to take primacy, for them to make those inquiries, which in the past we perhaps would have taken.
Right, thank you very much. I've got a list. Okay, so I've got Debs, Kim. Thank you. Anybody else wants to? Yeah. Oh, hang on. Oh. Yeah. Everybody on this side of the room. I'll go with my first three, then I'll come back here. Okay. Deb, if you want to ask a question.
Thank you, and thanks for the update. So I work for the Integrated Care Board, but I was previously the Chief Operating Officer at Leicester Hospitals, so I know quite a bit about this issue. I think it's just reassurance for both the Health and Wellbeing Board and any of the public that are listening that actually both UHL and Leicester Hospitals and LPT have in their policy is a series of actions that they take into account and go through when somebody goes missing. And although contacting the police is part of that policy, it's not we're contacting the police and we're not, and that's it, that's not our problem. So I think you're right in saying that actually that people under healthcare are best cared for by health, but they can't obviously drop everything and go out and look for a patient that's absconded when they're looking after all the other patients that are in. So I think this is the right thing to join the conversations together. I think to make sure the policies are linked, and I don't know if you get the opportunity to have a look at the policies of both Leicester Hospitals and Leicester Partnership Trust. And indeed for Rutland, our surrounding hospitals, because it's not just organisations within this ICS that are involved, just to reassure yourself, but the ongoing conversations I think are helpful. So it's a comment rather than a question. Thanks.
Can I just in relation to that, just to give you further reassurance that there's been a lot of involvement of a lot of strategic managers and strategic partners. There is, I don't know if any of you sit on either the strategic or the tactical group, so you're clearly aware of that the issues have been discussed at high level. So it isn't something which we've just locally introduced ourselves. We have thoroughly involved all the partner agencies in coming to the processes and protocols which we currently are applying. Thank you, Chair.
Thank you. Thank you. Kim?
I think that's what the comment I was going to make as well. I just wanted to ensure that the public that are listening in and partners on the board, that a lot of work is going on and has been going on for over a year now around this implementation and how it affects us locally and how we can respond locally. Because there's already been some really good work locally that we want to build on, that we don't want to just dismiss. So we were doing an awful lot of this already, from my understanding. But it is about reassuring to the public that we will have strategies in place that if the police aren't the people to respond, there will be some understanding about who is that response to the public. So it's not about a reduction in services, it's just about a change in an agreed format of who does it, and that's more kind of for the public.
Okay. Dawn, thank you.
Thanks, Chair. Yeah, just to add to that from a children's services perspective, there's ongoing work in relation to children and how right care, right person relates to children's services. And I think we're quite a long way off agreeing joint protocols around right care, right person approach in relation to children and young people. That's national, it's not a local issue. Fully engaged with the strategic governance that surrounds this for the sub-region. And from a children's perspective, it's not just about kind of concerns for welfare, it's also about how police are discharging their duties in relation to safeguarding and how that fits with the right care, right person approach. And that's been done very much at a strategic level, but both sub-regionally as well as nationally. So I think it's worth this group understanding there's another piece of work to be done in relation to children and young people.
Can I take you up on that, actually? Do you have concerns about that being put in place and a better, or what's the word I'm looking for? A better system put in place that will have a good, I'm trying to think of the way, net, it'll catch everybody.
Let me help you.
Thank you.
Yeah, I mean, I frankly, we do have concerns from Children's Services point of view in relation to right care, right person. This isn't a local, I'm speaking from a national perspective as well as locally. And colleagues with the National Police Leads for right care, right person are working with the Association of Directors of Children's Services and the Department for Education as we speak to agree and produce a jointly agreed set of principles based on the right care, right person approach. But we do have some quite serious concerns around the implications for safeguarding duties. But work is happening.
Would you like to make any comment of?
No, I think we're fully aware of those concerns. And I know some forces have taken a different stance and they are treating children differently. In Leicester Police, as Dawn's alluded to, we're waiting for a national steer. I know it has been flagged and there are some concerns, understandably, in terms of how children are dealt with in the right care, right person. But in Leicestershire, I think in line with pretty much most forces, we assess any incident based on the threat, risk, harm and the vulnerability. And if we need to deploy a resource, let me just assure everyone in this room and also everyone listening as well that we will deploy a resource. We will always look to deploy a resource where there's any inference that someone's life might be at risk or there's a possibility of some sort of serious harm. So we'll always look to deploy a resource when we spot that.
Thank you very much.
Hi, now I think my colleagues have already covered the points I was going to raise. I guess just one aside really, it's just thinking, and very selfishly thinking about my mother in a local care home with dementia, and I know that there are people there that do abscond. Does the same apply to those properties as well, or are we just talking about their interface with the healthcare system?
At present, the focus is more on partner agencies. Again, what we do is we assess every incident as reported to us. So, for example, if we had in your situation, you say that the loved one has dementia. If there are concerns for their welfare or for their well-being, then the expectation would be that we would naturally get involved. The last thing we would want is for any serious harm to come to your loved ones.
Thank you. Mike, would you like to ask your question?
I was, but actually was going to ask about the situation as it relates to children, so the previous questions covered it.
Tim, would you like to?
Thank you, Chair. The only point I was going to make, because I was at previous meetings where one of the issues raised was that if the police are withdrawing from certain areas, the effect on staffing, particularly out of our staffing, is have we got the depth of staffing to deal with issues that may arise? Just another point I was going to make is I gather this was piloted in Hull. Is that correct? And it might be an idea, I don't know whether that pilot could be circulated to see how it worked out.
It was, I think, Humberside who were initially they called. The irony is, before Right Care, Right Person, we actually had something called MAA, and that was Most Appropriate Agency, and it was very much the same principles, as in that we were looking to make sure that it was the most appropriate agency that took the lead to deal with the incident and to support the person. We have worked with Humberside, we've been up and we've visited, we've made sure that if there are any key lessons for us to learn as a force, and also I think Humberside are naturally part of the national RCRP working group as well, so a lot of liaison has been undertaken with Humberside, not just by us, but I think the College of Policing as well. They very much held up Humberside as a beacon for us, so a lot of that learning has already been shared.
All right. Thank you. Anybody else want to ask any questions? Janet, thank you.
Yeah, thank you. I just wondered how many people actually go missing in Rutland in, say, a year or a week or whatever.
I wouldn't have the figures for Rutland. I know for Leicestershire and Rutland, we take about 6,000, I think, missing persons reports in totality, but that can be anyone who's missing for a short period of time, or some people who might be missing for days. So I haven't got the figures specifically for Rutland.
Is that in a year, or the 6,000? Is that in a year?
I think that's in a year. Yeah, it's in the 5,000 and 6,000 usually go missing for a year, but a lot of those it's short term. It might be someone missing from a children's home. It might be someone who's just needs some time away from the family for a day or two. 99% of those will return. So I haven't got the figures for Rutland, unfortunately. Do you want me to get you those figures for Rutland at all?
It was just, I had no idea, so I thought.
Right, okay.
I didn't know the depth of the problem, so to speak.
It's a huge national problem, I think, with a fair comment.
Yeah.
Anybody else like to ask any other questions? So just what I think one from our side is, are we providing enough support to you to take this forward?
I think it's been a gradual incremental process, isn't it? Because the one thing which we do want to make sure is that the partner agencies, that you've got your structures and your processes in place. It's good to hear that you've obviously got policies which are already accommodating the fact that there is more expectation in terms of the activities and things which you guys will be undertaking before you report into the police. So I'm not getting the vibes that the partner agencies are not supportive of it, but I think what's happening is obviously sometimes just resourcing for partner agencies is sometimes quite challenging. We've had a few occasions where some of the frontline workers haven't been aware of the RCRP principles in some of the establishments that we've worked with. So again, it's just really trying to ensure that, clearly there's a good level of knowledge in this room, but ensure that the knowledge is filtered down to those on the front line who are actually going out there and doing the doing. And so when somebody is reported missing, or when somebody does walk off from a healthcare establishment, etc., that they actually know what to do. So again, it's just making sure the front line are fully aware.
I think that's it. So thank you very much for sharing that with us, and keep us informed.
Okay, thank you for your time. Thank you.
Thank you. Bye-bye now. Now moving on to agenda item number 9, Rutland Health Protection Annual Report. We're pleased to welcome Fiona Grant, Consultant in Public Health from Leicestershire County Council, and Anuja Patel, Strategic Lead Health Protection, Leicestershire County Council. So if you'd like to come and present, thank you very much.
Good afternoon and thanks for having us here. So we're bringing across the 2023 Health Protection Assurance Report to the Health and Wellbeing Board to provide an overview on health protection performance, key incidents and other significant matters. The report has been prepared with contribution from key partners across the system to assure the Director of Public Health that processes are in place to protect the health of the population. I must note that there is reference to an LCC strategic plan which has been inadvertently included in the report. There have been some significant changes in health protection, such as the establishment of the Integrated Care Boards and the formation of the UK Health Security Agency. The report gives an overview of the 5 strands of health protection, which include outbreaks and communicable diseases, screening programmes, immunisation programmes, healthcare associated infections, and preparedness and response to incidents and emergencies. It's worth noting that the local authority doesn't commission the majority of these services which contribute to the protection of the population's health. However, assurance is sought to ensure that arrangements are robust and meet the needs of Rutland's population. First key aspect that the Health Protection Report covers is the prevention and control of infectious diseases. The report lists the roles and responsibilities of the agencies that we work with the Director of Public Health holding overall responsibility for the oversight of any incidents or outbreaks. COVID-19 is the first communicable disease covered in the report, and the first case in Rutland was notified in March of 2020. The first national lockdown was announced earlier in the same month, and the Director of Public Health produced a local COVID-19 outbreak control and prevention plan to build upon existing response mechanisms. The next communicable disease in the report is measles. A resurgence of measles was reported in England in late 2023, and at that point the majority of cases were identified in the West Midlands, predominantly in Birmingham. Locally, in order to prevent outbreaks, vaccination remains a key priority. The World Health Organization recommend 95% coverage of 2 doses of a measles-containing vaccine, and in England this is combined with mumps and rubella, the MMR vaccine, and it's given to children aged 12 months and the second dose at 3 years and 4 months of age. In Rutland, estimated coverage for 2 doses at 5 years old is around 85%. It's higher than other areas in the country that have had the outbreaks, but work remains ongoing to improve this. There were cases of diphtheria identified in England, none in Rutland, in new arrivals to the country. A local group led by the Integrated Care System was established to ensure that populations who were at risk could be vaccinated and that local healthcare providers were aware of the evolving situation. The next section of the report covers immunisation, and childhood and adolescent immunisation uptake is better in Rutland compared to the England average. This is essential to help protect the local population. HPV uptake continues to be a system priority, particularly because of the links between HPV and different types of cancer. It's offered to children when they're aged 12 to 13 years old and is delivered via the school-aged immunisation team. Rutland did see a decline in vaccine coverage in 2021 because of the impact of COVID-19 and local lockdowns. However, a catch-up programme was put into place and offered to all children who are eligible. HPV has now moved to a single-dose vaccine and will continue to work to ensure eligible people receive their vaccinations on time, and particularly looking at vulnerable groups. Seasonal flu. Uptake of the seasonal flu vaccination has improved since the COVID-19 pandemic, and performance in Rutland again is better than the England average. Performance also exceeds the World Health Organization's target of 75% coverage, and the flu letter for this year has now been released and will continue to work with a range of providers to ensure Rutland's population can access the flu vaccine conveniently. So that will be from GP practices and from community pharmacies as well. Priorities for 2024 for immunisations will be to continue to increase uptake of the MMR vaccine. as well as other childhood immunisations, to maintain uptake of influenza, particularly in high-risk cohorts such as care home residents, and increase uptake of HPV amongst both boys and girls to reverse the nationally seen downward trend. Commissioning responsibilities for immunisations will be delegated to integrated care boards by April of 2025, so we'll continue to have a view and see what that looks like and the impact that it might have locally. The next strand of health protection covered in the report is screening, and screening detects conditions within the healthy population who may have an increased likelihood of developing a disease. Overall, cervical and breast screening programs nationally have experienced a downward trend. Locally, Rutland has seen a similar downward trend in these screening areas as well. However, they are performing better than the England average performance. Bowel cancer screening, on the other hand, has nationally and locally seen an upward increase in uptake, which is positive to see. The next section of the report covers sexual health. The Integrated Sexual Health Service detects, prevents and treats sexually transmitted infections in the local population. From April 2024, the ISHS service provision is being commissioned as an independent service, and Rutland maintains the current agreement for a year to the 31st of March 2025, with the longer-term service provision to be procured this year. An online service has started this month to offer a range of testing options for sexually transmitted infections and to treat chlamydia as well. A sexual health needs assessment covering Leicestershire and Rutland was completed in 2023, with several recommendations made around STIs and can be found online. Tuberculosis is also covered. Prevalence of TB across Rutland remains low, and it's lower than the England average as well as the East Midlands average. Work will, however, continue to improve BCG vaccination uptake and TB screening eligibility criteria awareness. It's been identified that engaging with non-UK born arrivals at an early stage is key, and to encourage these populations to participate in screening and vaccination programs. Healthcare associated infections are also included, and many of these are preventable. The data is collated by the Integrated Care Board and covers Leicester, Leicestershire and Rutland as a whole. Roles and responsibilities are listed within the report, and a system approach is taken to respond to any healthcare associated infections. The Integrated Care Board's Infection Prevention and Control Team and local authority public health infection prevention control teams are in the process of sharing educational resources to expand IPC learning for both general practices and care home staff, including sessions on C. diff and CRO. A new ICS community of practice has been convened with relevant stakeholders and is in the process of identifying current system issues and developing and coordinating relevant strategies. For emergency planning, the local authority works with the Local Resilience Forum to undertake the annual exercise programme and to respond to incidents as they arise. We continue to ensure partners are clear on the response to major incidents, including roles and responsibilities. Contingency plans are also reviewed regularly, and risks associated with changing weather patterns have been identified, with mitigations in place for example, prolonged periods of hot weather. And then finally, the report covers air quality. We know that poor air quality poses a huge environmental risk to the public's health and can contribute to morbidity and premature mortality. Rutland County Council does not currently have any declared air quality management areas, but a local air quality strategy is being developed to prevent and reduce polluting activities. The LLR Respiratory Working Group, chaired by the ICB, plays a key role in linking air quality monitoring data, health data and clinical colleagues and processes together alongside housing. For 2024, we'll continue to consult and monitor planning applications that may have a significant impact on air quality in Rutland and to provide local support and relevant information to encourage potential sustainable behavioural changes and increased understanding of air quality in Rutland. So overall, we seek to assure the Director of Public Health that processes are in place to protect the health of the population and will maintain and improve progress on the key health protection indicators.
Thank you very much. Okay, do we have anybody with any questions?
Yeah, thank you, Chair. Not so much question, more was sort of an addition to what Anuj and Fiona's report has presented. So thanks to Anuj for presenting and both of them for the report. It's been a while since we've published a health protection annual report because COVID got in the way, but we used to do it on an annual basis. And I guess for me, the reason for bringing it here is quite rightly the business of the Health and Wellbeing Board is focused on that long-term improvements in health or about service changes, but actually how we protect the population from threats to our health and hazards to our health, be it infectious disease or major incident planning or similar. I think it's important, and I don't want the Health and Wellbeing Board to sort of not be cited on that. As Anu said at the end, it's a funny world for public health, because I think my statutory duty is just to be assured that plans are in place. But that seemed to disappear a long time ago. Fiona well knows that when she started on the day of the first official COVID case in Leicestershire, I said, don't worry, emergency planning and health protection is a fairly small piece of the portfolio, which as she keeps on reminding me is not really the case anymore, because we are heavily involved in outbreak response. The point being, hopefully the report reassures the board there's a breadth of nasties out there that organisations like Public Health, the ICB, LPT, UHL, social care are involved in dealing with, be it infection prevention control advice through measles, pertussis, etc. And I think that Anuj's last point is the key one. That in terms of kind of when we deal with things which are happening in Rutland, we work together well on a Rutland basis. A lot of what we do is inevitably done on an LNR basis because infectious diseases don't respect borders. But where that does happen, again, as Fiona and Anuj know well, inevitably there is a focus on the city because of the lower vaccination rates, etc. But they are effective in making certain that partners across LLR don't lose sight of Rutland's specific needs in that one. So hopefully it gives reassurance, both in terms of the current picture, which is not bad in terms of screening and vaccination rates. There's always room to do better, but also just being assured that Rutland is very much part of our planning.
I think you've got in one there. My question would be, what else should we be doing? Could we be doing? Is there anything other than increasing vaccination rates?
I shall look to my expert leads.
Do you want me to? I'll come in, Anuj. So in terms of trying to improve vaccination rates, obviously we work really closely with partners. So obviously ICB, NHS colleagues, voluntary and community sector, really across the board. And there's a lot of work going on, for example, trying to understand in terms of vaccination what some of the barriers are to that uptake. So, for example, doing some behavioural insights work with particular groups. So, for example, recently, Anuj was involved in some work with the traveller community to try to understand why their rates of MMR uptake are lower than other groups. So it's that kind of thing, really trying to understand what the barriers are, working together with partners to try to find different ways of, so for example, sometimes a mobile vaccination unit will be taken to a particular location. There's been a lot of promotion, webinars, all kinds of things to raise awareness of particular challenges we have. So, for example, measles, people may have been aware there's been quite a lot of coverage recently around that to sort of raise awareness of some of those infectious diseases and also improve access and opportunity for vaccination uptake. So a huge amount of work going on around that at the moment, but very much joined up with partners.
Thank you.
And yeah, I'm glad you mentioned mobile van, because I was going to say access to services again. Traditionally across LLR, that conversation would probably be around ethnicity and language. But from a Rutland perspective, advocating for the use of the mobile van to get out to our outlying communities. Although we've had, when we've done that for measles, we had a really good uptake in where they went, kind of with Oakham or Uppingham. But I know Anuj, Fiona, you managed to get the mobile van out to Rutland a couple of months ago.
Thank you very much.
Thank you, Diane. I've got a question on immunisations, particularly MMR, but also I'd just like to make a comment on air quality, if that's okay. On MMR, obviously we had a recent outbreak of measles, and every so often we seem to have an outbreak. I think the last one was in Pultalbert, was it? A few years ago now, and we seem to scrabble to get on top of it. I just wonder, do we know the best strategy to improve MMR? Is it through health visitors, the school, or family hub, social media? I don't know. If we did know, would it be best to concentrate our efforts on that particular route?
I don't think there's a single best way to tackle it. But priorities at the minute are timely vaccination, so making sure children receive their vaccine on time. And we've seen outbreaks mostly in younger children rather than in adults. So whilst it's important that everyone gets their MMR vaccine completed, it's really important that children, because of the way they interact with peers, that they receive both of their vaccinations as soon as they're invited.
Thank you.
Follow on from me. I mean, yeah, we could give chapter and verse on this one, really, couldn't we? I don't think there's any particular setting. I am, you'll know, as you would expect to see. I mean, there's a bit of a sort of slackening off in vaccination post-COVID because people are kind of allegedly vaccine fatigued. MMR comes with its own history around the Wakefield scandal as well. I'm tempted to say, of course, nothing actually gets an upturn in vaccination rates other than, it's going to sound horrible, don't waste a good crisis. Because to some extent with measles, people have got complacent and forgotten that in a small number of cases it can be a deadly disease for younger people. So I think the current numbers in Leicester City and Birmingham have probably impressed upon people's minds the need to get vaccinated in a way they might have forgotten.
Your air quality.
Air quality. Can I just make a quick comment? The reason I'm bringing this up because I'm on the Planning and Licence Committee, and recently we've had a couple of applications concerning quarrying, and it's come up particularly with small particulates of 2.5 micrograms. And there are ways that this can be screened for, actually, and real-time assessment. And while this came up, I also still take the BMJ. There was an article in there from the United States, which once again added to the growing body of evidence of how small particulates adversely affect health. They do have more effect than we previously thought.
Again, we could do a big session on particulate matter. Rutland, of course, is always different. There are some things you can do something about in terms of PM 2.5 and some things are harder. So if you look at that map of air quality and PM 2.5, the small particulates you referred to across Leicester, Leicestershire and Rutland, as you would expect in the city, it's worse because it's driven by traffic. Once you start looking at Rutland, you then start getting into sort of agricultural blow-off because of the small particles sort of, coming off the soil. So there are, overall, there's no particular hotspot issues with Rutland. As Anuj was saying, there's no air quality management areas. But there's always something for me, and maybe the quarrying one is a good example of making certain where industrial processes are in place that they are effectively, the environmental permits they've got, the screening that they need to put in place. I know that's more of a regulatory issue, but that's more the kind of things we need to make certain that's done.
Thank you. Kim, would you like to ask a question?
Thank you. It was the comment on overall cervical and breast screening programmes nationally have experienced a downward trend, and in Rutland that trend is also, but not as much as England. Just why do you think that might be, where the bowel screening is coverage is as the uptake, but the breast and cervical? And also the next part of that is, what role do you think women's health hubs will play in trying to increase those rates, if any? Well, thank you.
So I think in terms of the screening overall is obviously in no small part reduced as a result of the sort of COVID gaps. So obviously there's still been some sort of catching up and a bit of lag where some of those programmes didn't run at all in the same way as they had done previously. So that's part of it. And I think you're still starting to see that. I think the difference with breast and cervical screening and bowel cancer screening is that they've developed a new way of testing that they use for bowel cancer screening, which is the one through the post rather than having a more invasive procedure. And so the thinking is that that's made it a bit more palatable for people to opt to take the bowel cancer screening. But there's a lot of work going on to try to improve those other screening programmes, particularly for women. And I think you're right, the Women's Hub, those hubs could play a key part in trying to sort of make some of those services a bit more accessible and more appropriate for the women that they want to particularly target. I don't know if there's anything.
Okay, thank you. And Janet?
Thank you. Couple of very quick questions. The first one is that I'm surprised that you haven't got the antibiotic-resistant Pseudomonas down as something, as an infection to worry about, because I keep hearing odd rumours about it being there and not very nice, etc. And my second question is, I noticed that you say bowel screening eligibility has changed. What has it changed to?
I know with bowel screening, there's been an additional clinical condition has been added as part of that. So that's what the change is. I don't think there were any other changes, were there? Not sure. Yeah, it was just one additional clinical condition that was added to eligibility criteria.
So for the antibiotic resistance, that's covered by the Integrated Care Board, and our role as a local authority is much more restricted, which is why it wasn't included. So it's not that it's any less important, it's just that our role is, it's a bit distant from what the ICB are doing.
Thank you. Are there any other questions or comments? No. Well, thank you very much. Very, very detailed, very, very fantastic read. No, I did. Sorry, that sounded sarcastic, but it wasn't. I was really, really enthralled by it all. So thank you very much indeed. We now have a slight change in our agenda. We're going to move on to item number 11. Right. So I'd like to draw this discussion to a close. The motion is that the board notes the Rutland Health Protection Annual Report 2023 and recognises the specific health protection issues that have risen locally, steps taken to deal with them, and the particular areas of focus for the coming year. All those in favour, please raise your hands. Anyone against? Any abstentions?
Thank you, Chair. That's unanimous.
Thank you. Okay, so we'll go back to, we're now going to go on to number 11. We're swapping 11 with 10. The okay, did you hear that? I would like to propose that I'm going to swap the agenda from number 11 to number 10 so that Sarah Prima can leave. She has somewhere else to go. So do we all agree that we swap those two over? Yes, thank you. So, sorry about that. So item number 11, Leicester, Leicestershire and Rutland LLR Integrated Case System ICS update. So report number 62 2024 from Sarah Prima, Chief Strategy Officer of Leicester, Leicestershire and Rutland Integrated Care Board. So could we please present your report to the board, Sarah?
Thank you, Chair. I'm okay until 4 o'clock, so hopefully this report won't take that long. I'll take the paper as read, but there's just a couple of things I wanted to point out. You'll note there's a couple of changes in personnel in the ICB, a new chief exec, and we are in the process of recruiting a new chair. That process is still ongoing. I think very importantly, I will just want to touch on the specialised services delegation. So these tend to be low volume but high cost interventions that have, since CCGs came into existence, before ICBs were in existence, were actually managed by NHS England as a directly commissioned services from providers, for example, from acute specialist providers and from mental health specialist providers. But there is a wide range of services that cover specialised There's over 100 lines of specialised services nationally, and 59 of those services have been delegated down to ICBs from the 1st of April this year. So ICBs are now responsible for the management of those services. And there's a range of services in there, including renal, cardiac and cancer services. And as I say, they tend to be lower activity but higher cost items. As an Midlands region, we have decided that we'll manage those across the region, mainly because of the fact that they're low activity but high cost. And the BSOL, which is the Birmingham ICB, is going to manage those services on behalf of all 11 services in the Midlands. That doesn't mean that LLR will not be involved in that work. We will, and we will make sure that we can develop those services in line with the needs of LLR population. But I think that's really important piece of information and change that's happened in the last few months. And as previously mentioned in the previous report, over 24-25, we'll be working on bringing immunisations and vaccinations delegated down to ICBs, and also another 29 of those specialist services will be delegated in 25 to ICBs. The other thing I just wanted to touch on is that our yearly operational planning is underway. The plan is due to go to NHS England on the 2nd of May, and for an ICB board sign off towards the end of this month, so just before the 2nd of May. So at the point of which those two things have happened, either the ICB has signed it off or NHSE and England are happy with the plan, it will be published publicly. It's still working in progress at the moment, so not available for publication. And I think the other important thing is to say that we have put in an expression of interest for the Work Well initiative, which I think if we get that bid will be really important to LLR, but we still await the outcome of that bid, hopefully sometime this week, because they did say they'd let us know by the end of April. So I think they're the important things I just wanted to point out, Chair. Thank you.
Thank you, Sarah. Are there any questions about that, the content of that paper? Yes, Mike, thank you.
Yeah, thanks, Sarah. I suppose I'm just thinking about the delegated responsibility, and I get what you're saying about doing it on a regional basis, and we'll have an input. I suppose there's a couple of things for me. I'm not quite certain. So take kind of specialised cancers. There's clearly something about doing it on a regional basis because of low volume. But does that then extend into the delegation also looking at the kind of prevalence of those specialised cancers, and would we pick up, I suppose from a Rutland point of view, would we pick up anything, who would pick up a sort of an understanding that a cancer, and I can't think which was more prevalent in this, as well as kind of access issues about rurality. It's almost like what's the scope of the delegation, I suppose.
So we take on everything in relation to that particular pathway, if you like, in terms of it's already done on a regional basis, to be honest. And also cancers, I wouldn't say it's more complicated, but there is a cancer network and an alliance which also sits at a sub-regional level, I think, which does a lot of that work that you're talking about. So I think the benefits will be to link the local work, the local intelligence, particularly around some of the things we just talked about access and how you get into populations, with that regional work that has been ongoing for a number of years. So I think the benefits of delegation will bring those two things together.
Any other questions? Okay, thank you. Sarah, it's up to you. You can stay or you can go. No, done number. No, number 10. I want number 10. Number 10, which is the Rutland Whole Systems approach to. Oh, sorry, hang on.
Yeah. Yes.
I have got. So thank you, Sarah. I'd like to bring that discussion to a close. And the motion is that the board notes the update from the LLR ICS. And all those in favour, please raise your hands. Anyone against? Any abstentions? Thank you. Now been resolved by the board. Thank you. So we will now go back to number 10, Rutland Whole Systems Approach to Healthy Weight. I don't think I like this, just thought I'd tell you that bit. We'll now receive report number 57, 2024 from Adrian Allen, Assistant Director, Delivery, Public Health, and Mitch Harper, Strategic Lead, Rutland Public Health. Adrian and Mitch, would you like to now present your report to the board?
Thanks, Chair. Yeah, Mitch is going to do the presentation. Thanks.
Thank you. Just bear with 1 second while we're just starting to present, and I'm going to share some slides. Okay, brilliant afternoon, everyone. So yeah, I'm going to present an item on a whole system approach to healthy weight for Rutland. I'm going to take the paper as read, but I'm just going to highlight a few areas to contextualise this as well. So in terms of why it's important, maintaining a healthy weight can improve quality of life and reduce risk of some health conditions. There's some link to obesity on the right there, but it's just important to note that this is around promoting a healthy weight. So it's not just around obesity, it's not just around overweight. We're also incorporating underweight and malnutrition into consideration. But this infographic just demonstrates the significance from an unhealthy weight in terms of risk and around various health conditions that are preventable. So there's lots there that you can see within that infographic. There's also significant cost considerations in terms of the impact of overweight and obesity related ill health. A lot of this content does cover overweight and obesity, but like I say, it's more so than that. So in 2014-2015, there was an estimated NHS cost of 6.1 billion related to overweight and obesity. When you add in the wider society costs, there's an additional 27 billion as well. So you can see the significance of that. That is national, as you can imagine, but plays through at a small scale for Rutland as well. That was 2014-2015. Likelihood based on the trends of what we're seeing are that has increased even further. We have commissioned weight management services within Rutland and across LLR. Some of those related to Tier 2 are commissioned through the local authority by the Public Health, and some are through the Integrated Care Boards in the more specialist Tier 3 and 4. What we can't do is rely on these services on their own. Whilst they may achieve their outcomes in terms of weight and reduce risk of various conditions, they are individual focused, and when I present the data in a slide or two's time, you'll see the significance of that and how we can't necessarily reach a population level intervention through individual behaviour change alone. Sorry, it's a bit slow to change. There we go. In terms of the data for Rutland, this just presents overweight and obesity for adults, reception year children and year 6 children as well. Focus on the adults, 55.5% of age 18 plus are overweight or obese as of 2021 and 22. A very rough, crude estimate of how that equates to population size. There's around 33,000 adults in Rutland. So there's around about 18,000 who are overweight or obese in Rutland. That is statistically better than the England comparator, which is just under 64%. What we want to allude to on this, though, is that doesn't necessarily, it may mean we're good in terms of the comparator to England, but that doesn't necessarily mean we're doing well and we don't need to worry about this. It is still the majority of our adult population at 55%, And like I say, based on the previous slide, the implications for cost and health conditions are quite significant still. So even though it might come across as green when you compare it, it doesn't mean it's all rosy from that point of view. When you look at obesity alone, it's around 20% prevalence for Rutland, which is around 6,500 people. And that again is significantly better than the England average, but the same point resonates as what I just made. Focusing on children, reception age, it's about a fifth of the reception age population. That equates to just under 200 children, of which there's 750 at the time of census at reception age at that point. So that is statistically similar to England, so we're not better on that indicator, but obviously as time progresses, although these trends are quite consistent, the children change within that reception age by year. And then when we look at year 6, it increases from that reception age from the 22% up to about 28%, which equates to about 250 children. So in terms of what we could do, oh, it's not changed. I'll start talking and it will change in a moment. But in terms of what we could do about this, so like I say, we can't necessarily rely on individual behaviour change alone. That is part of the picture, but it's not the sole thing. What we can do is look at a wide range of things related to a complex picture in terms of causes and risk factors. The infographic here is an evidence-based approach to this in terms of a whole system approach to healthy weight. You can see there's 9 strands to this, and there potentially will be more if approved and as we start to delve into the detail. But these cover all things such as how we can create a healthier food environment for people to adopt healthy behaviours, how we can look at creating healthier workplaces from a healthy eating and physical activity point of view, similar with schools, linking in active travel, an education piece, and also how we promote the local opportunities and community engagement as well. So you'll see there's a wide range, and this pretty much comes into everyone's business across the council and partners as well. And you'll see there's a lot of social, economic and environmental focus as well as lifestyle related stuff, which brings in the wider determinants of health. A lot of this covers the life course approach, so it's not just adults, it's not just children, it's looking at all ages because there'll be different interventions and different policies and other bits that we could do at different levels. And the intervention types are very different across these as well. So some of it can be related to policy levers at local level. Some of it can be national policy that we look to adapt locally. Some is around that health promotion and educational piece, and communication, engagement and education as well. So it will change again, but in terms of what's already happened, we've started some conversations on this in Staying Healthy Partnership. There's broad consensus that this is something that we should be looking at from a strategic point of view and coordinated point of view. And we've started to build some narratives, some of which is reflected in the paper that you've received. We've started to look at some of desktop mapping around those 9 strands that we presented on the previous slides. So we've looked at what the current activity is, what the gaps are, and where potential opportunities are. And we've started to very initially score those in terms of the strands and trying to look at where those priorities may be going forward. There does need to be more detail added to that mapping, but it's just a start point to help inform any decision making at this point. The scoring as a 1-page overview is presented in Appendix B of the paper. And what's important to note is that it doesn't necessarily mean we've got a lack of provision in those 9 strands. Some of them may have a lack of provision, but there is a lot of work already going on across all 9 of those at varying levels. And some of this is around how we can coordinate and focus on how we can do things differently, whether that's targeting those population groups most at risk, or whether it's influencing policy in areas where people are best placed to change things, whether that be planning, whether that be transport, or other areas as well. The scoring and the priorities are likely to change over time if it's taken forward, and it's a long-term approach to this, so it will like I say, as the detail starts to get added, priorities change, opportunities change, whether that's locally or nationally. Those scorings and priorities will change with time. The proposal then is set out in more detail in the paper, but just to give you an overview, the recommendation is that we consider a proposal for Rutland to commit to a long-term whole system approach to healthy weight, and that would be led by the subgroup, the Staying Healthy Partnership. There's another infographic here, and it does touch on obesity, but again, it's healthy weight orientated now. And I'm not going to go into this in too much detail because it is largely a project management approach that you would be familiar with. But phase one is around setup, which we're on that journey at the moment in terms of strategic buy-in and building some narrative. Phase 2 and 3 have started to happen to some level to help inform that phase 1. So like I say, some narrative has started to be built, some desktop mapping has started as well. If it's approved to go forward, we'll look to take that further in terms of the detail that's within those 2 sections. And then over time, that will look to inform what the action may be. It is acknowledged that some of the actions that are identified within this may carry a resource ask, and that may hinder progress in certain areas. So there's some things that we can do within existing capacity. Some things are worth getting on the table as and when those opportunities present, whether that's nationally or locally with funding opportunities. And over time, that will start to be mapped and managed within the Staying Healthy Partnership and reported back to the Health and Wellbeing Board as appropriate. And that will constantly be under reflection and refreshing as things progress. I think that is... Oh, sorry. So 2 alternative options. These are in the paper, so I won't dwell on these too much. It will flick over. So option 2 is continuing as existing. So there isn't currently a strategic focus on healthy weight in Rutland. While there is activity going on across those 9 strands that I mentioned, there's limited coordination from a strategic sense. So it's difficult to know where gaps and opportunities may present themselves. Weight management services will continue to be commissioned in current arrangements, but like I say, we can't rely on that solely. And then the third option is whether we wanted to hone in on one of those 9 strands or a couple of them and really look at the detail of that and how we can take that forward. The limitation of that would be that it focuses on a certain area and excludes others. So the overall outcomes in terms of healthy weights may not be achieved while we focus too much or too heavily on 1 or 2 sections. So that's it. And then it's just a couple of recommendations that are in the paper for the committee. I'll leave that with you, Chair.
Thank you. Any questions? Yeah, Debs. Anyone? And then Mike. Any more? Got Debs, Mike? No. Okay. Thank you, Debs.
Thank you, Mitch. Really good papers. Absolutely. Fully supportive of the whole systems approach. We can't underestimate the impact of weight on a whole host of long-term conditions, and it's been proven in all of the work that we're doing in long-term conditions. So it influences all aspects of healthcare, mental health included. I just think it's useful to let the board know that the ICB clinical executive has approved a review of a system-wide review, so that covers Leicester, Leicestershire and Rutland, wide review of weight management services, because there are discrepancies that exist in the provision of services. I'm really encouraged that from a Rutland perspective, we want to concentrate on this and its importance, because there are certainly opportunities or sometimes easy cuts on services like these, and it is really important that we keep them going. But I would like us to link in with the system-wide approaches as well. I think they'll have things hopefully to learn from the approach in Rutland, so we get that sharing across the board. And in terms of that, I know that you referred to there might be some areas where funding might cause a problem, and we always know that that's an issue. But in terms of true integration of health and social care and the work of this board. And we do have the Better Care Fund. There isn't a lot of money available in that fund, but it's certainly something that we should look to should we get recommendations that come forward, because this has massive implications on a whole host of services, both in health and in care across the system. Thanks.
Absolutely, thank you.
Yeah, thank you, Chair. So, yeah, no surprise to find I'd be supportive of the whole systems approach to healthy weight. That's possibly not the biggest surprise to anybody to this afternoon. And it's not to sort of say, well, actually, what about 3? But before you put the options on, I was looking at Appendix A and the scores. They are all important. And I know you said, Mitch, that scores might change and, you know, we need to complete the mapping. If I was looking at those, though, generally, we're scoring ourselves higher around the kind of things that maybe people would think of first, working in school settings, doing on the health promotion, health education side of things. We're scoring ourselves lower around kind of environment planning, active travel, making the environment more conducive to physical activity. So in my mind, I'm thinking, I want to say 1, but if I was going to put effort into it, thinking about where we've got opportunity and where we can get really big drivers, you know, it's probably the ones around planning and active travel, physical activity environments. Because my question was going to be, is there anybody that leaps out, or an organisation that leaps out at the moment in terms of who's not on the Staying Healthy Partnership that you would want around that table or this table? And just to pick up on Dev's point about that, I think you're right, Dev, just beware of the system review. I did ask that comes to the Health and Wellbeing Partnership, aka the Integrated Care Partnership, because I think it's important that comes to a partnership arena, not just the ICB. So that would join in, but I'm almost less concerned about weight management because of the kind of draft score that you've put there. So slight comment, but then a question you might want to come back on.
Want to comment on that?
Yeah, no, good point. And we do have some of planning and transport represented in Staying Healthy, which obviously from the food environment on new developments in particular, it's a big opportunity for us. And I guess with the scoring and prioritisation, depending what those interdependencies are over time, will set some of that, such as the local planning development. It offers us a great opportunity now, and that would help with that prioritisation of bumping it up. Whereas in a year or 2, planning may be lower on it and something else swaps through. So yeah, but they're largely represented, but we wouldn't be so insular in the Staying Healthy Partnership if there is opportunity to look at other projects outside of that representation.
Thanks, Mitch. Let's pass on to Tim now, please.
Thank you for the report. I hold wholeheartedly behind the whole systems approach. I mean, as a GP, I sat at my desk and saw a series of people asking for weight help with their weight, and we had drug reps producing that drug, all entirely useless. I mean, I don't think Wegovy is going to be any better, basically, in the long run. So, and I'd just like to back up what was said, because I think it's the combination of healthy eating and the exercise as well that is the important bit here. There's the other thing to add. I don't remember, I had a meeting with you about looking at the data, and I did look at the fingertip government figures data, and you know, I sort of looked at obesity. I noticed that one area was really quite below the national average. That was Richmond. I did, you know, it's down, I think, 5% at reception age. I just wondered, you know, why was that? But it actually doubled up to year 6, still well below the national average. And again, what causes that? It's just interesting to know these regions, why there is the weight gain in those particular years.
Yeah, I mean, I don't know a lot about Richmond, if I'm honest, but in terms of the data that plays through, like I say, it is at that point of that year 6 or reception age children. So technically it is a whole new group of children for the following year. But a lot of the trends do tend to be consistent. So it does make it more valid than that alludes to, I guess. But yeah, and they are small numbers and it's often a sample, so it is difficult to play through. But there's lots of examples of whole system approach to healthy weights that have happened. So we will be looking to incorporate a lot of that learning into Rutland, especially where it's in more rural areas such as what we've got locally. So yeah.
Thank you very much. Sarah, I'd like to ask your question, please.
Yeah, so I support the strategic approach, and I think we need to do it strategically, but I do wonder whether there is merit in, because of scarce resource and time, I do wonder whether there is merit in concentrating on certain areas of that journey that you put up on the screen, and to get some quick wins and to work with the people that you can have most influence over at this, where your levers are the most to start off with. So a little bit of what Mike said, but also work with those that have got the levers already so you can get some quick wins. So I completely agree we should take a strategic approach, but I also think we might need to think about how do we then target that strategic approach along that journey snake up there.
Any comment, Mitch?
Yeah, I agree in terms of the quick wins and getting some things in place that, just as looking at this in general, will help to push along.
It builds momentum.
Yeah. And I guess those, like I say, we've took this as a desktop mapping piece, but the next stage is mapping in a more broad sense and bringing the community involved with that in terms of engagement. And so that will help to inform that in terms of priorities, and hopefully there'll be some quick wins that we can play through from there.
Thank you, Mitch. Oh, Deb's, like another question?
Sorry, I don't know. I wouldn't often do this, but I'm just curious about Rutland's figures being better than the national average. And thinking of adults, do you think that there's anything to do with, we've got a growing elderly population, and we know that the elderly tend to lose weight towards the end of their life, and whether the comparator of the age range affects that position. And I suppose what I'm saying is it's support for, we shouldn't rest on our laurels, because the damage from healthcare will have been done at an earlier age.
The indicator that was, it's a good point, the indicator that was presented there, I don't believe breaks down by age, but we can talk to our business intelligence just to see, because if we can control for that, that will help to inform that data set. I think one of the big things that does stand out is that national evidence around obesity and overweight does show in more income deprived areas higher rates than the lower income deprived. So there might be some natural play through from that for Rutland, but we haven't seen the evidence locally to fully link those two together. But yeah, we can look at the age and, like I say, try and standardise for that as much as possible so we can see whether that's at play or not.
Thank you. Any other questions? No. Okay, so I'd like to draw this discussion to a close. The motion is that the board approves for a long-term whole systems approach to healthy weight be developed for Rutland, and approves the approach to be delivered by the Rutland Staying Healthy Partnership subgroup. All those in favour, please raise your hands. Anyone against? Any abstentions? No. So that's been resolved, that the board has approved for a long-term whole systems approach for healthy weight be developed for Rutland, and approved the approach to be delivered by the Rutland Staying Healthy Partnership subgroup. Thank you.
Chair, can I just add a slight rider to that based on the 2 points that have been raised? One, that whole systems approach, but I think Sarah's point's important, that we look for opportunities for quick wins with targeting, but that we also link to the LLR system-wide review, again, to see if there are any opportunities for joint working, and again, quick wins. Thanks.
I think that's perfectly feasible. I don't think it changes what we've just agreed, but I think there needs to be perhaps a codicil to go with it to recognise and include those. Thank you. We're now moving on to number 12. This is going to be an online presentation. So this is the Joint Strategic Needs Assessment updates and timeline. The first part is the chapter on mental health and dementia. It's an adults focused report number 602024 from Hannah Blackledge, the lead public health analyst, Leicestershire County Council, and Amy Chamberlain, senior public health analyst, Leicestershire County Council. So Hannah and Amy, are you both? I've got one of you. Do we have the second? Hang on. That's Amy. Oh, Hannah's just not showing. Hannah's
I think the camera might be off.
Blob at the moment. Thank you. So over to you now, Amy. Thank you.
Chair. I'll just share my screen for a presentation.
You just talk again, Amy, because you were very quiet then.
Yeah, can you hear me?
I'm still very quiet. Let's do some technical fiddling. Amy, hello, talk to me again, please.
Hello, Chair.
Still very quiet. Can you make sure you're close to your microphone and that you talk as loud as you can? I don't think we're going to get much louder, so you may see some confused looks. I will tell you if they're looking confused, don't worry.
Yeah, please do.
So Amy, over to you now. Thank you.
Perfect, thank you. So we're going to pull out some of the main findings and headlines of the Mental Health and Dementia Adults JSNA, with more detail available in the report that's been distributed to you all. Hannah and I will be happy to answer any questions that you might have at the end. So this JSNA is an update of the 2018 Adult Mental Health JSNA chapter, and it includes a more detailed section on dementia than was available in the previous JSNA for Rutland. This JSNA includes comparative epidemiology, GP disease register, survey and service use data. And we have acknowledged in the report that there are some caveats with the publicly available data, so including things like the time period for which it relates to and its reliability, with small counts in the data for Rutland sometimes making it difficult to determine significant differences. So the JSNA outlines some risk factors. So there are many risk factors and groups at risk of poor mental health, including those with protected characteristics. And these are discussed in detail in the JSNA. So we've reviewed these groups systematically in the full report, and this slide just kind of pulls out some of those which are most relevant to Rutland. So, for example, we can see older adults, they experience higher prevalence of mental health conditions, particularly dementia. And we know that Rutland has an older population compared to the national population, with a steeper projected rise in the older age groups in Rutland than nationally, which is likely to exacerbate this difference in the future. We also have, for example, we know that armed forces personnel are at increased risk of post-traumatic stress disorder, depression and anxiety. And we know that the proportion of Rutland's population aged 16 and over that reported previously serving in the UK Armed Forces was significantly larger than the proportion in England. So the JSNA has considered these groups at risk in the report. The mental health needs section of the JSNA, so this covers the national and, where available, the local estimated and recorded prevalence of common mental health disorders, as well as severe mental illness, suicide and self-harm, dual diagnosis, eating disorders, and also mental health service use. So on this slide here, none of the prevalence figures here for common mental health disorders are particularly surprising. We can see low prevalence of depression compared to nationally, increasing trends in depression in accordance with the national trend, and with almost all dementia diagnoses in those aged 65 and over. What is interesting here, though, is the estimated dementia diagnosis rate. So here we see that less than half of those aged 65 and over that are estimated to have dementia actually have a dementia diagnosis recorded on their GP register in Rutland. And this is significantly worse than the national average and the benchmark goal. And it suggests that more than half of those living with dementia could be going undiagnosed and not receiving any treatment. So this is looking at the mental health needs with regards to severe mental illness. So with the prevalence of severe mental illness, we found that the number of people on GP practice registers across Rutland with a diagnosis of schizophrenia, bipolar disorder and other psychosis was significantly lower than the national average. And we also found that the prevalence of severe mental illness on GP registers was lower than what was expected from the estimates. Now, this data can indicate that over half of people experiencing severe mental illness could be going undiagnosed. So the table here on this slide, it outlines some of the outcomes in those with severe mental illness. And as expected, the data shows that people experiencing severe mental illness are more likely to have adverse health outcomes. So we can see that the risk of premature mortality in adults with severe mental illness in Rutland was almost 4.5 times higher than in adults without severe mental illness in 2018-20, and this was similar to the national picture. The outcomes data is though based on small numbers, so does need to be treated with caution. But with poorer outcomes identified, we deem it important to look at scope for prevention and early diagnosis to improve these, some of which is likely possible through physical health checks and cancer screening. However, we did find that as of June 2023, less than half of people registered with severe mental illness across Leicestershire and Rutland had completed a full NHS physical health check in the previous 12 months. And in East Leicestershire and Rutland, the breast cancer screening coverage for women with severe mental illness compared to the general population was relatively low also. If we move on to suicide and self-harm, there were 45 emergency hospital admissions due to intentional self-harm in Rutland in 2021-22, and this equates to a significantly better or lower rate than the national average. The number of suicides in Rutland were low, so we found that there were a total of 7 suicides in Rutland between 2020 and 2022. However, again, estimates indicate that the number of people having thoughts of self-harming and or attempting suicide each year in Rutland could be much higher, which indicates a potentially higher level of need than is being evidenced by the service use. The JSNA covers mental health services for adults provided through the NHS and other community organisations, and the services are primarily commissioned and operate across Leicester, Leicestershire and Rutland, and cover a range of talking therapies, mental health units and teams, inpatient and outpatient services, services for specific mental health conditions, services provided specifically for older people, support provided by practitioner partnerships, and also voluntary and community-based services. Now, as a result of this joint provision, most of the publicly available data on mental health services is only available at ICB or sub-ICB level, rather than at local authority level. The main report contains some outlines of these individual services, and then there are some further details available on these services in the appendix. So moving on now to the identified needs and gaps of the JSNA. So we identified that population trends and projections, such as steep projected growth in the older population and a large projected rise in dementia, point towards increased mental health needs in the future. A need for further investigation of the mental health needs of Rutland's armed forces population was also identified. In adults with severe mental illness, as discussed, both the breast cancer screening coverage and the proportion receiving a full physical health check were relatively low. Gaps were also identified between the estimated prevalence and the number of patients in contact with health services, and this may indicate unmet need, particularly for dementia, for severe mental illness, and also for self-harm / suicide. Across Leicestershire and Rutland, there were perceived gaps in the continuity of care between emergency department and general practice for people self-harming, particularly those without a permanent local address. And then also across Leicestershire and Rutland, there is a perceived lack of flexible outreach for people sleeping rough and perceived low uptake of treatment for people with personality disorders. So if we look now at the recommendations of the JSNA, these include to seek opportunities for prevention and early detection of mental health conditions, to monitor and improve the uptake of physical health checks and cancer screening, so particularly among those with severe mental illness. To recognise and address issues associated with Rutland's rurality, such as access to services and hidden pockets of deprivation through improved joint working. To enhance the continuity of care for those experiencing self-harm. And then also to improve access to mental health services, so particularly in communities where there may be a stigma associated with living with a mental health condition. There are also some more intelligence-based recommendations of the JSNA, and these include assessing and monitoring the effectiveness of the Rutland Women's Hub service, which is currently being mobilised, to ensure that this service is meeting the needs of women in Rutland. To enhance local data collection on mental health inequalities, prevention and services, particularly for vulnerable groups such as pregnant women and armed forces populations. And then also further modelling of the impact of current demographic trends, so looking at those projected steeper increases in the older population and the impact of these on future mental health needs and demands for healthcare. And then finally, to assess in more detail at a local level the needs of some of the at-risk groups identified, such as prisoners, travellers, and also armed forces personnel. So that kind of covers some of the key take-homes of the mental health and dementia adults JSNA, and Hannah and I are happy to answer any questions that you might have.
Thank you very much, Amy. So, okay, I've got my Debs. Oh, I can't do it. I'm sorry, the pen's not working. Ian, Tim. Right. Oh, we've got to go at the end then.
So
Lovely. Thank you very much. Debs, start with you, please.
Yeah, first of all, thank you for the report, really comprehensive. I suppose my question might be more for Mike, and it's he's frowning at me. It's a general question on statistics, really, because there are quite a few of the elements related here that suggest that we've got lower levels than we would anticipate having in Rutland, and yet. And I get what a benchmark, that having a benchmark target's important, but with a smaller population, we know that small differences in numbers can have an adverse effect. But also, we've got better survival rates, for example, in Rutland than compared to the national average, and we accept those. So it's a question of why don't we accept lower detection rates on some of the things? Why is it automatically that people are suffering not detected rather than there being a lower incidence? If that makes sense.
Yeah. I think so. I mean, I looked at Amy and Hannah. Part of me would say it's the difference between a kind of population level where, because it's kind of more of a sample, you would have a confidence interval around it and a variation. But if you're looking at no, that doesn't make sense. I was going to say, if you're looking at a detection rate, you just kind of detect them. But luckily, Amy's got her hand up. So I'm going to shut up.
Amy, would you like to answer that, please?
Yeah, so I think, are you talking about the difference between the prevalence estimates and how we're saying that there might be a gap between the estimated and the recorded prevalence, and that this might mean some people are going undiagnosed?
Yes, that's it.
Yeah, that's because we're looking at different sources of data. So the registered prevalence are those that have been diagnosed with the condition at their GP practice. And then we're also looking at some national prevalence estimates and applying those to the population of Rutland to identify estimated prevalence of the conditions. And therefore, if we compare them, we're kind of seeing that when the estimated prevalence is higher, we're identifying potential people that aren't actually registered at their GP practice with that condition. Does that make sense?
It does, and I understand what you're comparing. I suppose what I'm suggesting is that some populations have better health outcomes than others. So the suggested prevalence, when do we accept that the suggested prevalence might not be right for that population because they might be healthier? I suppose is what I'm getting at.
Yeah, I think that's a great point, and there's always shortcomings with those estimates, but they sort of the best we've got. and something that we can't ignore, if that makes sense. But we adjust them as well as we can for age and mainly age and sex, and a little bit for deprivation. But it's very likely that the true prevalence is actually lower. It's closer to those demand, but even national, particularly for the over 65s dementia estimates, that is the national standard approach. So sort of we can't ignore it, but we need to treat these estimates with a big pinch of salt. Basically, it's likely that Rutland actually truly has a lower prevalence, but it's all triangulation between the estimated, maybe hypothetical numbers, the service use numbers, whether it's primary care through QOF or secondary care contacts. And out of that, you get some picture, but we have to report that there is a potential gap. It's a potential gap. It's not a detected gap. It's a potential one. Does that make some sense?
It does, thank you.
Thank you, Hannah. Pass over to Mike now, please.
Hannah, just picking up, I guess for me, it's the difference between an estimated prevalence and a modelled one. Because if what you're saying is, I mean, it's not like we've just applied a national estimate to Rutland's population and gone, this is the figure. If that's taking account to some extent in the modelling for differences in age, etc., then it should have, subject to what you're saying about everything, has a level of imprecision about it, does at least allow for changes in the population. So, you know what I mean? It shouldn't be a gross error, should it?
Yes. So therefore we are reasonably confident that this is properly adjusted, definitely for age and sex in all cases. Some of the national estimates, although dementia national estimate, it's also just adjusted for age and sex. So demographic structure is adjusted for very well. What may not be adjusted for that well is the levels of social deprivation, but I don't think that would change those estimates hugely. It's probably less, but it's not. There are problems, but as I said, the national dementia estimate is only age and sex adjusted as well. So we're pretty confident these are good estimates, but they still just estimates, not the detected. Detected. The only way of dealing with it would be to do a well-designed local survey, but the closest is we've got decent national surveys and current population structure. Does that make sense? I know it's a technical thing, but
Thank you for that. That's very detailed. Thank you. Are there any other questions or comments? Ian, I thought you might want to.
Yes, thank you. Good afternoon. My name's Ian Crowe. I'm the Armed Forces representative here today. First of all, can I say excellent paper, thank you. And I really appreciate that you've put in an Armed Forces community section and highlighted the importance there. I would take issue with what you talked about with regards to the recommendations. You talk about looking in more detail at Armed Forces personnel. For me, regular Armed Forces personnel are comprehensively looked after by the Defence Medical Services. My real concern for Rutland is the veterans community. You rightly point out in your report that 6.9% of the population are veterans in Rutland, and you're going to hate me for this. On the 5th of April, the ONS produced the latest research they've done on statistics with regards to suicides amongst veterans, and it was startling. They talk about males between 25 and 45 years old are twice as likely to commit suicide if they have served in the armed forces. And I think that's such a telling piece of research that we need to make sure that any work that we do includes and focuses on veterans in the community, because we must address that. The other point I was going to make was, is it too late for you to adjust your report to include that latest research and include that ONS reference? Because I think it's very telling and very important. So 2 points. First, focus on veterans, and second, can we include a reference to the latest research? Thank you.
Amy or Hannah, would you like to answer that?
Sorry, I still have a hand up, so I may answer. I think the report actually, yes, I'm aware of these. I think it was out of once we've sort of finished drafting, so sure can include that if we wish. I think as we did try to find more information on veterans, but that actually the report represents what was at the time of writing. We sort of have to put I think end of February was the cut-off point for collection of all the data and evidence for the report.
Thank you. Looks like Alice. Oh, don't keep.
Thanks. It's just for the board to note that obviously to do an analysis on suicides to know whether somebody's served, you can look back to see if they've served. But to be able to do some prevention work, we need veterans to be identified. So we do have a scheme within the NHS and locally within the ICB about GP accreditation for veterans, and we are trying to encourage the population who have been who are veterans to register with their GP as a veteran, so we can help process that information.
Ian, would that answer your question, or would that be enough, or do you want more?
No, that's fine, thank you.
Alison, sorry.
Thank you, Chair. And Amy, Hannah, thank you for this. It's a really timely report. LPT are just about to start work to develop their new strategy for 2025 onwards. So it will be a useful insight into us being able to tailor that to local need. I guess I've got a couple of points, and Deb's raised one of them. One was the automatic assumption that we don't accept the figures around the lower prevalence rates across Rutland. I think seeing it written down in black and white, some of the recommendations that you made, I think once it's written, once it's read, once it's seen, it stands, and it has quite negative connotations for us in terms of how we plan our services going forward if it isn't accurate, if we are looking at lower prevalence rates. I guess the other area that I would just like to pull up is, especially in relation to dementia and to mental health, that it is not entirely a health response. It is a system response. When we're looking at mental health, there is something about early intervention and prevention, which is a public health responsibility, working with our partners in the local authority to a social care response. And I would like to see us move towards a much more social model as opposed to a medical model when we're starting to look at and tackle and address some of the issues that are related to mental health. So especially things around the homelessness agenda, being actually, able to hold down a job, work. It's multifaceted. It is not purely a health response that we'll be looking for to respond to this JSNA. So I think that's important to mention and to caveat in this report. But no, thank you very much. Really, really timely. We look forward to it being published. I'm hoping you're happy that I can share and start to use this internally to inform our approach in developing the strategy going forward. And it might be helpful actually to have a separate conversation outside of this meeting to follow up with you both.
Thank you. Any comment, Amy or Hannah? Probably not. Right. Dawn's in front, I'm told, and Kim.
Thanks, Chair. For those who don't know me, I'm Dawn Godfrey. I'm the Director of Children's Services, Rutland. Really interesting and really good report. A couple of questions from my perspective. Obviously, it's an adult mental health JSNA, I think I'm right in saying. There is reference throughout, sometimes to 16 pluses and sometimes to 18 pluses. which in my world, 16 plus is still children and young people. But so first question was, is there an intention to do a JSNA around children and young people's mental health? So that's the first question. The second question was really around the section that talks about at-risk groups, and actually being explicit about at-risk groups, particularly care leavers and children from overseas, and particularly our unaccompanied asylum-seeking children and young adults. And I think it'd be really powerful and important that those two particular at-risk groups are referenced explicitly, because we know that they are two groups who have particular traumatic experiences that can affect their mental health and their mental well-being. And I think it'd be good to see that kind of referenced explicitly within the JSNA, but more widely. Is there an intention for a JSNA in relation to children and young people?
I'm not sure anyone would like to comment to that. But
yes, so I think I would envisage that the Best Start for Life chapter would probably pick up an element of that, but there isn't currently in the plan a specific chapter on mental health for children and young people. So we would need to make sure that that's added into the Best Start for Life.
Can I make a request that as a board we have we say that that should happen?
Yeah, I should make that statement. Mike, do you want to say something to that? Yeah,
I'm sort of looking to colleagues really. I can't remember the last time we had a discussion about the work plan for the JSNA at Health and Wellbeing Board, because I'm happy to go if the board think we need to insert that, fair enough, but something's got to get knocked out, so we need to bring something back that says what are your priorities, and we'll work it from there.
That's a future thing that we can look at that. But yeah, Dawn, we will take that on board and add it in.
Just to reinforce that, I would actually agree with Dawn wholeheartedly. I think post-COVID, it's a system, it's a real system risk in terms of that early intervention prevention agenda. Otherwise, we're going to have another generation of people with fairly significant mental health issues.
Absolutely, thank you. Where am I up to? Oh, hang on, where am I up to? I've got my list here. Sorry. I've got Tim waiting very patiently and Kim. So we'll do Tim and then we'll do Kim.
Well, thank you very much for the report. It particularly brought out for me the trouble that people with mental health issues have accessing physical health. For example, you brought out the breast screening as a particular one. I think what's not mentioned here in access to mental health service is it needs to be timely. In my experience, if mental health issues are left for a long time without someone assessing, they can escalate to be much more of an issue. And I think that needs to be brought into the report. Thank you.
Thank you, Tim. So I think we need to take that on board if we can, or at least make that note. On to Kim now, please.
Thank you. Really comprehensive report. Thank you very much. Just a couple of things. The dementia strategy, the LLR dementia strategy, has been signed off at Cabinet, so that is no longer in draft. And just for kind of wider listening, if people are listening in, that although the rate, dementia diagnosis rate is that you put 49%, that has increased over the last 6 months due to an anticipatory care project that was through ICB, PCN and Rutland County Council, Admiral Nurse Services and the RISE service. So that trajectory has changed and the diagnosis rate is increasing. The other couple of things are just around information for work for the IDG and the supporting good mental health work stream of the health and wellbeing, that noted that the uptake of breast screening of those with severe mental illness is lower than it should be, and also the suicide and self-harm, number of people having thoughts of suicide is higher in Rutland, and I think there's some pieces of work that we could start to look at locally in Rutland, what we do and target work for those areas. Question around perceived lack of outreach for people sleeping rough. There was something on your PowerPoint. Be interesting to understand that a bit more, because our numbers are extremely low. In fact, I can tell you probably who those people are sleeping rough. Yeah. So I've been, and I do know that they do have outreach support. So just interested where that data came from.
Over to you, Amy or Hannah.
That was more of the feedback from Leicestershire and Rutland commissioners. So I think somewhere in the text we say that this is the footprint of commissioning footprint for some of those. But we didn't find at the time anything that was specifically Rutland rather than Leicestershire, East Leicestershire and Rutland. So
I think Debs wants to come in and make a comment.
Sarah's probably going to say the same thing. Okay, so we don't have a Leicestershire and Rutland commissioning footprint anymore. That disappeared when we had it at the ICB.
Yeah.
So I think it's important. I didn't pick that up in the report. Sorry, I should have done. So I think it's important, and Jason, is that we alter the wording on that, because the old CCGs don't exist anymore.
Yeah. And therefore that piece of information probably needs to be amended.
Sarah, would like to make a comment?
Yeah, I do. I was going to talk about the dementia diagnosis rates actually, but what Kim's just said is really important, and I think we need to get the figures updated, because I thought we had been doing quite a lot of work about getting the numbers up. So I think we need to get the current data in, and then say that we have got an ongoing project to increase the prevalence rates, because at the moment it looks as though they're quite low, and actually they're not.
Sorry, and I just don't reply to that. That's, if we can reflect that, I think that would be really useful, because that's ongoing work as well. It's not just it's a pilot, but it will be after the evaluation ongoing work. And also the MP for Rutland has also got a dementia campaign this year in place. So it's really important to reflect all the work that's happening.
Right. Catherine would like to comment.
Just a quick point leading on from that. We do have more up-to-date dementia diagnosis rates, but we can't split the Rutland from the East Leicestershire.
But I think you can interrogate GP systems to get that data.
Okay. We need to look at how we do that then.
I think we have a bit of a...
Collect it by GP practice.
Amy, would like to make a comment?
Yeah, and I was just going to say that we'd need to make sure that anything we put in the JSNA would be publicly available data. If we're drilling down at those lower levels, we can consider putting the small counts in the report.
And I think that's a fair comment. So I'm not quite sure what we should be suggesting now. The numbers we don't think are reflective of what's happening, but we're not sure whether we can get that data available for everybody. I think at the time it was written, it was probably quite right. So has it already passed its date? Is it now out of date? This
well,
paper.
if it's difficult to get the exact data, I think it has to be put into context about the work that's being done to increase that diagnosis rate.
So what would you like to recommend, Kim? Is there anything we should be doing? Oh.
Sorry, Sarah, can you put your microphone on, please?
I think we should need to go back and look at the published dementia diagnosis rates, because I can't remember off the top of my head how often they are published. So I think that's one thing. The second thing we need to do is to look at Rutland GP practices and what their rates are. Now, that might not be publicly available data, if you know what I mean, but
it feeds into the prevalence rates, because that's how they get them. They get it from GP. That's where the data comes from. So before we make a decision on whether we need to change what's in that report in terms of numbers, I think we just need to have a look at where we are now on what's available. But I do agree with Kim, we need to qualify that statement by saying we're doing lots of work in this area to increase rates.
Right, and the only thing I'd like to add there is about the fact that diagnosis is not actually a very accurate tool at the moment, skill. It's based on, you know, a number of things, so it can be quite wrong at times. But I think we have got a concern, as Kim says, we need to know what's happening. So I'm suggesting, what am I suggesting? Wait, Hannah, you've got your hand up.
Sorry, it's probably historical, but chip in. Yes, I mean the data are for the. I think the data is there. It is a nationally published figure that 48 something percent. So it stands as for that period of time, and that's the one published. We can qualify it in the sense that there is a work ongoing and there are indications of increasing rate locally. But because of the statistical sort of nature of that document, I don't think we'll be able to include a lot of new information, if that makes sense. And it's also comparative. I mean, that's from fingertips, so they estimate the rates nationally, and they adjust it and compare it with other national areas. So it was true at the time of that statistic being drawn, but maybe not accurate now.
Fair comment, true at the time. Let's turn to Mike now, please.
Yeah, so I was going to suggest I'm wary of getting into publishing nationally available data and then saying we think it's wrong, because things might have moved on, but what the public's supposed to believe, you know. So rather than kind of go, can we pull out this data and refresh this, because Hannah says, you know, sooner or later we've got to draw a line underneath it. What I would suggest is, clearly as a board, we need to take on board these recommendations or not. I think taking on board the recommendations gives us an opportunity then to then say, well, what's the response? And the response is, what we're doing about it, what do we think that difference has made to the data? So I want to wrap up, if we could, a discussion about how things have changed and whether the data is accurate or not into a conversation about doing something about it instead of going back for a further iteration.
Yeah, Ben in circles, thank you. Janet.
Yeah, I was involved in the Health Watch report for dementia, both across the LLR and also for Rutland, and I've been trying to follow the discussion of data, etc. But I don't have the figures in front of me, but from what I recall, the estimated number of people with dementia in Rutland was much higher than the 7 that is mentioned in the report, and was actually mentioned to us by the Admiral nurses when we were doing the background research. So if you go down the avenue of checking the data for adult prevalence, can I ask that somebody absolutely clarifies the young onset dementia prevalence as well, please?
I think this is all work going forward, all of this, so that and I think, as Hannah says, the data at the time was correct. It was what's nationally available, but it may no longer be correct. And what we do about that going forward is we look and get what can we do to actually make it much more accurate, based on what Mike was just saying. So thank you for that. Are there any other questions, comments, observations?
And the data is not correct. There potentially is more updated data. Yeah.
So I think we've had enough conversation here, and I think we need to draw this discussion to a close. I'm not sure that we could approve, and I don't know if I have anyone else's opinion here, because we're asked to approve the Mental Health and Dementia JSNA for publication, supports the findings and recommendations of the JSNA and notes the contents of the JSNA. I would say that as it was written, yes, we probably could. And if anybody has a comment on that, or should we put a comment at the bottom saying this needs to be reviewed? I'd like your reaction. So I think all those in favour of publishing as is, please raise your hands. Okay, so we've got 1, 2, 3, 4 in favour, and those against, 1, 2, 3, 4, 5 against, and no abstentions. So I think we will take that forward to another meeting to clarify what we're doing with the data and where we're going. Mike?
I suppose that's going to be my question is who gets the job card to take it forward? Because clearly there's some organisation, as Alison was saying, would want to have a discussion, but it's not for Hannah and Amy to be charged with leading the implementation. And again, I think, you know, coming back to the point and what we've just voted on, yeah, there might be a lot of things that we want to say and do about, say, dementia diagnosis. Do we honestly think that there is no problem with dementia diagnosis? I don't think we're saying that. So I think the broad recommendations stand. There's then a question for me about what then comes back to the board and who's doing it and who's taking it forward.
Oh, Sarah.
Can I just check the numbers? Because I had my hand up for accepting, approving. So can we just check the numbers?
Okay, we look like we're at stalemate now.
So I think I could be persuaded the other way around, but with one rider on the report, particularly the bit about armed forces and dementia and armed forces and veterans, that actually the recommendation should be about veterans and not about serving armed forces. Yeah. And if we could have a statement in there which suggests that some of the data since publishing the report has improved or we think has changed, then I think that will allow us, when our conversations with the public, given it's a public, it'll become a public document. I'm just conscious that we need to be able to be assured that what we're signing off we believe to be the case.
Okay.
I don't know if that helps or not.
Yeah. Sorry.
For me, it's just the amendments that we talked about, and Amy and Hannah. So the outreach and the sleeping rough, just to clarify that, because that looks like it's Leicestershire data, not Rutland data, and the context of we're doing some more work around the dementia diagnosis to increase it, and it's again that context is what I was asking for through my. Which, if we have assurance that is in.
My instinct, and this is from where I'm sitting, is to say that it's what was produced at the time. There are perhaps need to clarify and update as a separate entity, and Mike's going to frown at me now, I think.
No, I'm kind of with Kim. I think I would separate out where the board wants to see a different definition because they think it's important. So veterans, I think, is great to me. I think the rough sleeping one, again, is more like an egregious error because I think we put Leicestershire data in when it should have been Rutland, so I think that's right. I think the kind of, again, I'm wary of going, don't worry, folks, things have got better because that's what it was at a point of time, and then we need to take it forward. Otherwise, we run the risk of, you know, what happens if things get worse? Do we go back and say, oh, actually, we shouldn't have published that one? So 2 out of 3 for me ain't bad.
Are we willing to accept that modification, the veterans and the rough sleeping, and perhaps a comment that these were the figures at the time it was written, and therefore if anything else comes ahead and it gets used as evidence, it has to be with that proviso, it was at the time. So should we change that? Oops.
Yeah, can I just add, it was the figures reflect the data available at the time rather than just these were the figures at the time. So there's that question there. Was the data correct? Because I have a feeling, especially on the young dementia, as I said, I'm worried about approving something as fact, when in actual fact, it's debatable whether it was fact. And I take Mike's point as well that, you know, how are we going to measure whether things have improved or not if we rely on the data that is possibly spurious in the report?
Hannah, would you like to make a comment?
Yeah, so in defence, the data were as published by national sources, by Office, the fingertips, and we can obviously it's not the veracity of the data is on the side of the Office for National Statistics, or whoever provided those for us. So they are as true as they were published. So we never know whether they're actually true or not. That's out of our hands. We're publishing that. We're basically putting in whatever's available to us. Yeah, so that was my main point about the veracity of the data. That will never be. The dates are there and the sources are in the document. With all the other amendments, we're happy to correct. Apologies for the RAF sleepers, because that was something that was basically one of the Leicestershire points. So I had my doubts from the start whether they should go in or not, but easy to. I think there is a zero of people sleeping actually, RAF in Rutland, some of the last surveys. So that's in the document too.
There's one.
Yeah, there's one now.
That.
Right. Okay.
So I think we've come to a resolution there that we will accept the board approves the mental health and dementia JSNA with those two amendments, the number of rough sleepers and the armed forces statistics, and to accept that the results of the research were based on data at the time. Yep. So that when it's used, it will change, sometimes for better, sometimes for worse. So taking that, can I do that? Okay, so does everyone understand what we're saying? Good. So all those in favour, please raise your hands. Anyone against? And no abstentions. Oh, you're abstaining. Sorry, Janet. Debs.
Sorry, Chair, and I'm not abstaining. I just think from this conversation, this leads to a piece of work I think we need to do in the subcommittees of this board to ensure that we have this sort of conversation before it comes to the board. So just my apologies as chair of the IDG in advance, because we should have been able to pick up the opportunities of these discussions to clarify our issues so that when it comes to the board, we're not having the degree of debate. So we'll take that action.
Thank you for that, Debs. Okay. So this is the joint health and wellbeing strategy. Before we start, I think I just want to share with you the good news that Catherine has been promoted. I want to embarrass you in public. And it's an interim 6-month acting up role. She's now the interim head of service for adult social care. So congratulations from us. Well done. So this is report number 58/2024 from Catherine Woodison. Interim head of service adult social care, but written when she was health and integration lead, which gives the board an update on the progress of the joint health and wellbeing strategy delivery plan and highlights elements of the public health outcomes framework. Catherine, over to you.
Thank you. Yes, so just a few bits to pull out from here. We have done some work on the strategy delivery plan, so we have a new updated version of that, which is has been included in the papers. And that's really just to try and help us focus more on information and reporting. There is still some work to be done on that plan, which will be done over the next quarter. I'm currently in the middle of doing a 12-month review of the strategy delivery. That will be available at the next Health and Wellbeing Board. What it has shown is a lot of progress in the work of the delivery of the strategy. Lots of new initiatives are now embedded and are working as business as usual. So we have had some hiccups, but there's a majority of really good progress in implementation. So a couple of examples here. The learning disability annual health checks for people aged 15 plus. Been a little bit concerned about, how much these are happening. So we've got some verification that we've got some good figures on those. There is also a learning disability annual health check pilot. So this is to help more complex situations, people who are afraid to come forward for their checks, so that team will go and visit people in a more comfortable environment, their own home and schools, etc. We've also got in the children's services a good process whereby they can highlight any concerns with anyone they're working with, an LD, who they feel needs to receive a health check. Just also wanted to highlight that the oral health team has been and visited the early years, done some early years sessions at the family hub around oral health. So that's supporting priority 1. For priority 2, a couple of examples is the Armed Forces Community Health and Wellbeing Plan has been developed, and there was February. There was a workshop that took place in February, and the delivery is now commenced. Making Every Contact Count training has started to be delivered across Rutland County Council Adult Social Care, and that we're driving that forward to increase offer and take up. Equitable access. GP surgeries have implemented a priority phone line to improve access for the most vulnerable patients or those at high risk, and some figures for the acute respiratory illness hub has provided over 300 appointments between December and February 2004. With regard to growth and change, I think we're all really aware of the levelling up progress. That is progressing with Government's Board and Delivery team. Meditech facilities will be at Oakham Enterprise Park, and there are indicative Moby Hub routes being identified. And some outpatient services are being delivered from RMH. An X-ray and ultrasound occurred 2 days a week. So just some examples of more closer to home access. And the Priority 6 Dying Well is really taking momentum now, since it's taken over by Samily Call. So the first steering group was held in January. It's really good attendance from a range of partners. Looking at exploring engagement and also looking at a population health management approach to Dying Well. And a productive pathway mapping workshop was held in March. It's just about really identifying what's already available, what the gaps are for receiving good services at the end of life. So just a few examples of progress. Then moving to the public health outcomes framework for Rutland. I've picked up a couple of things here. So, what we've just heard, it's the JSNA sounded a little bit concerning around mental health. One indicator of people reporting low happiness has improved from 4.7% in 21-22 to 3.5% in 22-23, and it's significantly better than the national average. So it potentially seems, you know, lots of good work that's happening, including the work of the Rutland Neighbourhood Mental Health Group. And something that we're not performing so well on is musculoskeletal, reporting long-term issue with that. Well, the figures are there, but I know one of the things we're looking at is a healthy workplaces project, and we know that depression can affect physical health, and workplace play a big part in that. So that's early stages, but that might have an impact on that issue. I'm just going to move over on the public health outcomes framework to Mitch, because there is a report about life expectancy and a concern around that. So Mitch is going to take that one for me.
Thanks, Catherine. So yeah, the first indicator that's expressed in the public health outcome framework is around life expectancy. So for those who have already seen, both male and female life expectancy for the year 2022 has decreased by approximately 2 years for both males and females. So it's something that's been highlighted and something that we wanted to explore for obvious reasons, because it's quite a significant decrease on that yearly trend. So some of the things we've found are that, sorry, I just find the slide. So excess deaths were high in 2022 for Rutland. That is the same time period as the life expectancy updates. So excess deaths were the highest in East Midlands, although all East Midlands areas in terms of local authority areas were above 1 in terms of a ratio on excess deaths. Rutland was the highest for that year. The positive side of that is that that has now decreased in terms of excess deaths only for 2023. So whilst we're still above a ratio of 1, we are quite considerably less than 2022 figure. So that alludes to an improvement, and excess deaths is likely a contributing factor to that life expectancy decrease. We've not got life expectancy data for 2023 as of yet, so we don't know what the impact of that reduced excess deaths has on life expectancy, but we will see that next year. In terms of a wider perspective of what that life expectancy decrease may mean, mortality rate has increased for a couple of conditions. One of our indicators is long-term conditions considered preventable. That has increased for the same time period, so 2022. And also circulatory diseases, mortality rate has increased for that 2022 year as well. Disease prevalence for those conditions has stayed the same. So it's not necessarily saying there's more people with those conditions. It's potential that there could be worse outcomes for those people with those conditions in the first place. Based on, just in terms of interpretation of this, it's very difficult to fully put into what the reasoning is. But based on the time period being 2022, there's potential that COVID-19 was still at play at that point. During the peaks of the pandemic, Rutland did have a delay compared to other areas in terms of the implications of cases, ill health and mortality related to COVID-19. So there's potential that that delay is playing through in terms of the outcomes from the pandemic as well, considering it is 2022 data. Also, as we always do with Rutland, we need to acknowledge that small numbers are a factor for Rutland. And while life expectancy is one of the most valid indicators for Rutland, the further trends moving forward will help to really highlight whether that trend is continuing or whether it is an anomaly for that year. Like I say, we're in 2024 now, so we've not seen 2023 data play through or 2024 as of yet. There is also a 3-year trend for this data, so for life expectancy. That does show a decrease for male and female, but as you can imagine, as this is a one-off going down at this point in time in terms of the data available, the 3-year data hasn't gone down as much as the 1-year data, if that makes sense. So for the 3-year data from 2020 to 2022, Rutland is significantly better still for life expectancy, both for females and males. So that is a more valid measure because it's over 3 years. We can be less influenced by those small numbers. So part of that is a wait and see, but also what do we potentially want to look at now? So yeah, that's where we've got to with that review.
Right, I've got Debs and then Mike. Thank you.
Thank you, and thank you both. Clearly, we need to do a bit more work on that position, but I've got a data query. Given that we have imports of elderly population into Rutland because of care homes and some of those issues, does the life expectancy based on anyone currently living in Rutland, or is there any criteria about how many years you've had to live? Because if you're coming in with ill health and significant, for example, if you move from Corby to Rutland, Corby's got one of the lower life expectancies, then you bring your life expectancy with you, or does it go from birth, or just a query on how it's calculated?
I think more important is to remember it's based on standardised populations, so it does take account of differences in the Rutland population. I mean, the answer to your question is it's probably based on where you die as opposed to where you live. But it shouldn't be such an issue because ultimately you're controlling for those differences in population.
It's just we have seen an increase in population coming in from outside, as I understand it, because of the care homes. So people who weren't in Rutland before, which is putting pressure on care home. That was my reason for asking. But actually, we need to triangulate the data with our long-term condition data in health and what's happening anyway, and to see where the treatment gaps are and what we can do to try and cover that off.
Thanks, Debs. Mike?
So, just thanks to Mitch for this one. I mean, I don't want to set hairs running, but it is a concern because we're Rutland and we don't do worse in the East Midlands for health, and certainly not on such a central indicator as life expectancy. I do think it's interesting. I would hope, as you were saying, Mitch, that this is a bit of a delayed reaction because we know that life expectancy nationally took a big hit in COVID for 2020/2021. We didn't see that drop in Rutland. I think we had probably the least drop in life expectancy for that year. But we've then seen it deteriorate in Rutland the next year, whereas the rest of the country has fared not so badly. So I'd like to think that almost like the first wave got shoved into the 21/22 figures, and then the big 2021 January wave got a little bit later in Rutland, and that got shoved into the 21/22 figures, if you see the logic of that. My fear would be, and the more worrying one, is something related to the population, Deb, as you were saying, but we do know that, you know, if you've had COVID, there's been an increase nationally in terms of deaths from CVD because of the after effects of having COVID. It's not directly related. And recognising that Rutland figures can vary a bit because of small numbers, I think it's definitely one to keep a watching wait on, because if it is a delayed curve of COVID and it bounces back, great. If, though, our population is such that it's more at risk, if you like, of the after effects on general health due to having had COVID in the past, then obviously that's a longer term problem.
Right, any other comments, questions? Janet?
Yeah, I'm just wondering if, again, associated with COVID, but there was a general reticence of people to come forward for medical attention during the height of the pandemic. There was a lot of fear about when we were in lockdown, etc. And has that delay in seeking medical attention also come through in the figures as well.
Do you have any comment, Mitch?
I think the only thing I'd say is, well, one, yes, that could be at play, but if you look at the trends compared to other areas, Rutland is a little bit different. But again, going back to that delayed part of that, that might have been played into that delay as well. So if you look at the timestamp at that point, i.e. 2022, Rutland is a bit of an anomaly compared to others, but it's whether that's a delay or whether that's different, because all other areas would have had similar issues in terms of what you just raised, at varying levels, I'm sure, but there would have been some of that at play for all areas, not just Rutland.
Janet?
Except that with a much older population demographic than other areas, and as the older people knew they were much more at risk if they caught COVID, perhaps that fear factor played in more in Rutland than, say, in Leicester City, where the demographic is a lot younger. I don't know if you're the expert.
Yeah, I mean, it's a consideration. Obviously, to quantify that is very difficult, but yeah, it's another consideration, and it might be multifaceted. It's not just one thing that's probably contributing towards it.
Ian?
Sorry, Mitch, there's one obvious question, and that is, when's the next data set? So when is the next update on these figures, so we know whether we're trending down or trending up?
So unfortunately, it's an annual update, so it would likely be, I don't know when it was exactly released, but the first couple of months of 2025.
Everyone had their comments. So I'd like to draw this discussion to a close. The motion is that the board notes the further developments of the JHWS delivery plan and notes the public health outcomes framework update for Rutland report. All those in favour, please raise your hands. Anyone against? No. Any abstentions? No. Okay. Okay, we'll move on to number 14, Better Care Fund. Just conscious of the time now. So we now have report number 612024 from Catherine Willison on which briefs the board on the 2023-25 quarter 3 BCF report. Catherine, over to you.
Sorry, Catherine, can you put your microphone on, please? Thank you.
Yeah, report is focused on the quarter 3 BCF report, which looked at, so I'll be quick, which looked at metrics and also spend and activity on certain areas of the BCF 2-year plan. I talked, so the metrics, as we talked at the last meeting, are Rutland set metrics. They're all in the report, but I guess just to say that the metric for discharge to the usual place of residence has improved in that quarter. What hasn't improved and is not on track to meet target is avoidable admissions. So numerically wise, the number over the quarter is 43 above the target that we set for ourselves in Rutland. What I did include in the report was the work that is happening on the health and care collaboration, focusing on comorbidities and risk strategies, etc., and also things like the WASAN boxes in care homes. So obviously the health and care collaborative work is still progressing, and we hope to see some impact of that on avoidable admissions. Just one metric there. And the spend and activity that needed to be included this time, it's just on certain areas of the plan that I've listed here, so carers services, etc. Absolutely no issue with that at all. That's all on target, and that's fine. and just that the Rutland BCF Partnership Board is still happening. That's meeting every quarter, just as a governance around Rutland BCF rules and processes. And we did, the board did approve monies for 2 schemes. One was the Community Inclusion Officer, and one was a customer feedback contract that's being delivered by Health Watch. Thank you. Any comments or questions?
Anyone got any questions? Anything? Right. Okay. So we haven't really had a discussion when we've heard from Catherine. So thank you. The motion is that the board notes the content of the report and notes that the Rutland 2023-25 Q3 report of the Better Care Fund gained approval from the Chair of the Health and Wellbeing Board and from the ICB Executive Team and was submitted to the National BCF Team on 31st of January 2024. All those in favour, please raise your hands. Thank you. Yeah, that's everybody. So that's been resolved. Thank you. Moving on. So the update from the subgroups. The first subgroup we're going to be updated by is Dawn Godfrey, Strategic Director for Children and Families. So an update from you, Dawn, please.
Thank you, Chair. Just to say, I actually wasn't in attendance at the last Children and Young People's Partnership due to leave, so Councillor Smith obviously chairs the partnership, so may be able to give an update from that actual meeting. What I would say is the current Children and Young People's Plan runs till 2025. We're starting next month to look at to start the planning for the priorities and the new plan from 2025 to run through to 2028. So the planning for that is already starting. And the priorities and the actions that had been identified for the current Children and Young People's Plan are now embedded within business as usual. So I think what I wanted to let the Health and Wellbeing Board know is there's been some really positive and really good progress and partnership progress in relation to our Children and Young People's Plan, and now we're in the process of doing the next one, and that's it from me.
Tim, is there anything you'd like to add to that?
No, I'm afraid I haven't. I didn't know I was going to have to give a report, but I think Dawn has fully informed us. Thank you.
Thank you. Thank you, Dawn.
Sorry, can I just add? The intention will be that we bring the new Children and Young People's Plan through this board. The earliest that anything will come through would be, I think, probably the October Health and Wellbeing Board. I know the dates haven't been set, but that would be the intention.
Thank you, Chair. So we received a comms update at our last IDG. A dementia subgroup is being set up. Got a lived experience partnership group in play, which I think is really helping in putting into how we look at services. And there was also a discussion on how we maximise the opportunities to connect with the voluntary sector and some of the initiatives that they have, particularly when we're publicising services or changes and picking up some of the issues like vaccinations, for example, as we go along. We are looking at our same-day access services and looking at how we can improve the model of care so it's less confusing to the public. So we'll hear more about that over the coming months. We reviewed our terms of reference and we've agreed to include a deep dive into each priority area as part of the integrated delivery group, and that would allow us to really focus on some of the risks that there might be to delivery that we can then draw attention to the Health and Wellbeing Board and also work out what further actions we need to do to address them. We received a presentation around dentistry. There's been a national action plan.
Debs, can I just, sorry, I'm so sorry, can I just stop you there? We've hit that wonderful hour of 4:30, and I have to ask whether or not you'll agree for an extension of the meeting time. We'll extend for 15 minutes, and we'll get it done by then, won't we? So, do we have to ask for a vote?
Yes.
All those in favour of extending? Sorry, Debs.
Okay, sorry, Chair. So we received a report on dentistry, particularly the National Action Plan and how it translates to Rutland. There's a lot of work that's required still on dentistry, as we know. We're awaiting the oral health needs assessment, which is due out at the end of May. A couple of the sort of elements in the national scheme involve new patient premiums, attracting new dentists and plans that they have nationally in doing that, an increase in the UDA payment, which is the Unit of Dental Activity, to try and encourage more NHS dentists. And there will be some recommissioning of UDAs in Oakham, which should come into play at the end of the year. So we recognise that dental is both a local and a national problem. We've got the commitment of the commissioning team to continue to update ODG, and I suggest that we request a report to come, an update to come to the Health and Wellbeing Board. I thought it was in September, but it might be October then, whenever the meeting is, or the December meeting, depending on the agenda, Chair. Thank you.
Thank you. Any observations or questions or comments? No.
Thank you, Chair. And I'm hoping that I'll be able to bridge that gap between all of the reports you've been receiving today, which have got 21, 22 sort of data on it, to operationally what we're actually doing about some of the concerns and issues that have raised in those reports. So hopefully I'll be able to bring us up to present day with this one. So the Rutland Neighbourhood Mental Health Group is led by Mark Young, who is our Senior Mental Health Neighbourhood Lead, continues to meet monthly. They have given feedback into that JSNA mental health and dementia chapters, and they organise meetings to work collaboratively with a number of partners, specifically Leicestershire Recovery College, P3, which brings in our mental health and housing, Vitamins and Rise Integrated Neighbourhood team. They also work very closely with public health, and one of the examples of that is recently they have been supporting the voluntary group that the High Five group have set up with the 5 neighbouring villages, where we identified an area that perhaps we want to support with areas of deprivation within them, to bring the group together to explore how they can support and improve the health and well-being in that area. Particularly RISE met with the group in March to discuss the current support offer, the Joy platform, social prescribing and carers. We had enormous feedback of, real appreciative. We're trying to get them to actually help themselves, not do things for them. And they now have introductions of where they can go for further support and advice, linking them into the wider voluntary sector network, which also meet on a monthly basis. Pepper's Our Safe Place, which is our crisis cafe in a previous naming, have now submitted their proposals for changes to their mental health cafe, which have been accepted. And one of those is looking at opening a hub in the town hall at Uppingham. We recognise that that will complement their existing offer in Oakham. They're actively recruiting new listeners and have received a good response to their advert. They're hoping to launch the Uppingham Hub in mid-May, and there has been a large increase in numbers of people accessing the cafe, 133% increase in the period from November 23 to February 24. Public Health have shared the draft Armed Forces Health and Wellbeing Action Plan 24-25 at a recent workshop in February, and one of the actions specifically for the RISE team was regarding how we can seek to reduce social isolation and loneliness in the regular Armed Forces families and how we can support them. We've spoken to the colour sergeants at Kendrew Barracks, and they have agreed for the RISE team to attend coffee mornings for family members and serving personnel to obviously increase that comms and that link into the Joy platform on all of the voluntary sector and self-help, and they're sharing some of that on their social media channels as well. We've also been supporting the Veterans Breakfast Clubs that are held in Rutland as well. We're finalising the revisions to our RISE integrated team leaflet so that we've actually got something physical to hand out to people, as well as supporting the launch of the Joy platform, which has now been launched across county, city and Rutland, linking us all in together. We've got roller banners displaying in Uppingham and surgery and Oakham medical practice to try and reach out to the public so that we can have some more of that self-help going off as well, raising that awareness. We've got Mental Health Awareness Week coming up in the week beginning the 13th of May, and we've been speaking to Active Together, looking at organising mental health walks, looking to start a mental health at the Mental Health Cafe. The walk will start from. And we know that walking can have profound positive effects on improving people's mental health, and several of the current Walk Together walks are focused on walk and talk, providing a safe space to talk with like-minded individuals whilst receiving physical activity. We're also organising a Wear It Green Day on Wednesday the 15th of May, and we're just finalising details of that. On another note, hopefully you may be aware that our local GP mental health lead, Dr. Cora, is leaving us in June, and we're actively working with our colleagues in LPT to secure funding to extend her role beyond June because of the incredible work that link has had with all of the mental health work. We're also linking in with LPT to discuss how we not only recruit the lived experience partners, which are working with our co-production and participation groups, but also a peer support worker to work with our local community mental health worker to support our group mental health sessions, which have been incredibly well received in the county. The Three Conversations community reablement worker is still working at capacity. They've started a weekly drop-in session at the Five Elements Cafe in Uppingham, and although it has had a low take-up to start with, the numbers are increasing, and that is purely a drop-in session. There's no prior, anything needed. People are just chatting, talking, and our Three Conversations worker works with people there. The Getting Help in Neighbourhood funding in round one that Age UK had for their befriending service was extended by 12 months into year 2, and we're pleased to say that it has been extended for a further 12 months, and Age UK continue with that very successful befriending service. We are waiting information on the annual health checks for people on the SMI register, the Serious Mental Illness Register, and we understand that GPs are going to be performing those physical health checks, which will release the mental health facilitators, which are currently doing them in PCN, to actually do more focused work with individuals. And we've requested the data about how many people we have got on the SMI register in Rutland. You will note that the report we had earlier was county and Rutland figures combined, and we have pushed for those Rutland numbers. We continue to work in young people's arena. The Section 19 panel MDT continues to meet every fortnight, and we have early help services, the GP for mental health lead, and ourselves looking at cases, particularly with children and young people with special education needs. And we are also meeting with Elisa Goodman from Age UK about dementia support services in Leicestershire, and Lisa has confirmed that she will be covering Rutland from April 2024. Mark Young has been facilitating the Community Mental Health and Wellbeing Team MDTs since the end of August. And involved in those meetings has been the GP health lead from the PCN, community mental health worker from RISE, the mental health practitioners and facilitators, mental health social workers, clinical consultant psychologists. And since March 24, we have also invited members from adult social care, particularly the front door adult duty team, and they are becoming regular attendees each week. That MDT has been incredibly useful for supporting those, particularly with complex needs, to make sure that there is a joined-up approach to supporting those people. There's a new project that was designed by a member of the RISE team and launched in February called Menopause Matters. The group meet monthly in the Oakham Refill shop on the first Tuesday of every month between 6 and 8 at night, designed to bring people together to discuss anything related to menopause. The first Menopause Matters social awareness group only saw one person attend, but they left with very positive feedback on social media. And since then, the second meeting had 3 people and the third meeting has had 5 people, with the original person attending all 3 sessions. So it's gaining traction. Very proactive with researching information to share with the group, which is very encouraging, as our aim for this group is to be completely sustainable without the need for anybody within our team facilitating the group. So, Chair, that's just a bit of a operational what's happening on the ground presently.
That's fantastic. Thank you very much. Any questions or comments? Janet.
Thank you. What a lot of work. Just wanted to know, and this was a question that somebody asked me and I wasn't able to answer, is how are RISE and the Joy platform going to sort of integrate, or is one going to sort of take over from the other, or?
So the Joy platform is RISE. They are both the same. So
right.
We case manage all of our support on the Joy platform. So the Joy platform is made up of 3 different elements. There's a GP element that they can actually refer directly into RISE from their System 1 platform into the RISE platform. And the RISE team are linked into the marketplace. The marketplace is the public-facing part of RISE. So all of our voluntary sector organisations are on that marketplace, including RISE. So the public can actually click on the RISE tile in the marketplace and directly refer themselves into RISE. So the Joy platform is RISE. It's all the same part of it.
That's all I needed to know. Thank you.
Yeah, thank you very much for that. So let's just we're now we got I think we're going to have to extend again. We've got about a minute to go before the next deadline, so are we happy to carry on for another 15 minutes to deal with Adrian and the annual work plan? All those in favour, please raise your hands. Thank you very much. Everybody in favour? Yeah, thank you. So we're now going to pass over to Adrian Allen, Assistant Director Delivery Public Health, on Staying Healthy Partnership.
Thanks, Chair. I'll keep it brief because a lot of these things have already been mentioned in other items. There's 3 core elements to the work stream at the Staying Healthy Partnership. The first one being the Armed Forces work. So the paper came to Health and Wellbeing Board in January. Following that, there was a workshop which was really well attended by partners and representatives from the barracks. The outcome of that is an action plan for 24-25 has been developed, and that plan is now working its way through. That process has been really positive from all partners, which is great. Just mentioned by Emma Jane the High Five project, which is the project that started in Greetham, changed names not so long ago. That continues. Evaluation now is on the agenda, and they're starting to look at how that project can have some sustainability moving forward, but also taking out the learning from that project and looking at how that can be replicated in other areas, which again, there's some really positive things coming out of that, which is great. And then the third work stream is around the whole system approach to healthy weight, which we've had a presentation on today, and which holds the detail. And that's it. Thanks, Chair.
Jim. So I think that's the end of that bit. So the next is number 16. Is there anything I've got to do there? No. Number 16, review of the forward plan and annual work plan. So what are we proposing for 24-25? Does anyone have any other items they would like to propose for inclusion on the board's work plan? And we'll take that. So as that you have any changes to be made. Thank you. So if anyone wants to email me with their suggestions, that's fine. Let me know, and then we can add it into there, and then we can have some exciting things in our work plan. Or do you want to say something, Debs?
I'm just going to say, so there are two things that we said we'd pick up, the new children's plan plus the dentistry. Email if you want.
There's always one. Any other urgent business? Not been told of anything in particular? No. Okay, so the date of the next meeting. We are setting the dates for all the meetings at the next, at the annual council on the 20th of May. So the dates have not yet been set. So we will let you know as soon as they've been put in. Is that all right, Mike?
Roughly, though, we still do quarterlies, wouldn't we? So after May 20th, we'd be looking at April, May, June, August, July or August.
We will let you know. So I declare that this meeting is closed at 4:47. Thank you very much, everyone. It's been excellent. Thank you.